Right. My name is Chris. I'm part of a psycho-oncology team at the Westmead Breast Cancer Institute. And this is a bit of a collaborative work. So it's myself, Associate Professor Kerry Sherman, who's also at the Westmead Breast Cancer Institute, but also Professor Sheila Ridner, and she's over from the Vanderbilt University. As I said, it's psycho-oncology, so it's a little bit more, as Julie put it earlier, touchy-feely than the physics presentation we just had. So breast cancer treatments that also involve surgery to the lymph nodes leave the surviving women at risk of developing lymphedema at some point in their life. And we know that 20% of all these surviving women will go on to develop lymphedema. And as a result, we have some simple behavioral strategies we recommend women to engage in, which help to minimize this risk. The most important out of all of these recommendations is that these women should be seeking medical advice at the first signs of lymphedema. There are two other recommendations that have some empirical support for their effectiveness at decreasing risk, and that's for avoiding extreme temperatures to the at-risk arm and to avoid trauma to the at-risk arm. However, engagement is less than ideal. It's usually about 60 to 70% in most studies. So we thought that we would see whether or not there's some psychological factors that might underlie this, and the research so far is starting to suggest that two broad categories of psychological factors is cognitive factors, so people's thoughts and beliefs about the risk of developing lymphedema, as well as the affective factors, their feelings and their emotions as a result of their risk. Now, if we focus on just the cognitive factors, I have a whole host of things I need to explain to you guys. So in terms of thoughts, we really talk about a woman's perceived risk. How much of a risk does she think she is at of getting lymphedema? Her knowledge about lymphedema, and the coherency of this knowledge. Does it make sense to her, or does this knowledge confuse her? In terms of beliefs, we talk about the beliefs regarding the recommendations. Does the woman believe that she can actually do these recommendations, known as self-efficacy? And does she believe that these recommendations actually work to decrease her risk? That's response efficacy. We look at her beliefs about control. Does she think she can control her risk either through self-management or through treatment? What sort of consequences does she think are associated with lymphedema? Is it a serious condition? As well as the timeliness of lymphedema. Does the woman think that it's a chronic disease? And when she is diagnosed, does she think that it's going to come and go? Or will her symptoms stay for the rest of her life? In terms of affect, the feelings and thoughts, at least for this study and for what we see in the research, there's a strong focus on negative affect or emotional distress. So how distressed does the woman get from her risk of developing lymphedema? But also too, we talk about self-regulation. Does she have the ability to control this distress? So the aim of the study, as I've already alluded to, was to really assess the role of these cognitive and affective factors in a woman's willingness to engage in these recommendations, specifically seeking medical advice, avoiding extreme temperatures, and avoiding trauma to the at-risk arm. So to do this, we had about 600 people, or 600 women sign up to our study, mostly from Australia, but we had a small portion of people from America as well. They were recruited from breast cancer community centres from both countries, and in Australia we also had the Breast Cancer Network help us out. All women had breast cancer diagnosis at least 12 months prior, had completed active treatment, and had undergone breast and lymph node surgery of some kind. All women completed online measures. So these measures included measures about their cognitive and affective factors, all those things I talked about earlier. And to do that, we used the illness perception questionnaire and some items that we've used previously in our research to really target all of those factors. And up there was just a couple of examples of the items that we had. In terms of measuring the woman's willingness to engage in those recommendations, we had simple yes or no questions, such as, are you consulting with your doctor at the first signs of lymphedema? Are you avoiding trauma to the arm? Are you avoiding exposure to extreme temperatures? We also looked at physical well-being as a possible covariate, something that might be related to why these women may or may not engage, but not necessarily our focus. We also looked at some demographics and medical variables that we know is related. So age, whether or not they're from Australia or America, symptom severity, the type of breast surgery that they had, and so on. In terms of our results, we saw that the majority of our sample were in their mid-50s. They were low symptomatic, but they were also highly knowledgeable about lymphedema. I do apologize, I don't know why that's displayed the way it is. But basically what that shows is that most women reported that they had 12 years or less education. Most women were living in an urban environment. Most women had taken anti-estrogen at some point as part of their treatment. They had undergone chemo and or radiotherapy. They had undergone a mastectomy as opposed to a lumpectomy. And the majority of women also said that they had undergone an axillary clearance as opposed to a sentinel node biopsy. Fingers crossed this doesn't happen on my next slide. Okay. If we compare Australians to Americans on these demographics, we see that we had more Australians reporting that they had lower educations, they were living in urban environments. More Australians had undergone axillary clearances compared to Americans, and more Australians had undergone radiotherapy. It's going to happen again. Yeah. And we had more US participants reporting that they had undergone a mastectomy as opposed to Australians. In terms of engagement in the recommendations, for seeking medical advice and for avoiding trauma, we saw what's seen in the literature. It was about 60 to 70% of people were adhering. And interestingly, our American population had a significantly greater proportion of women saying that they were seeking medical advice at the first signs of lymphedema compared to our Australian sample. Another interesting point is that avoiding extreme temperatures was actually quite low. It was only about 30 or 40% of women were adhering to this. In terms of our effective factors, and this is the nice graph, you're not going to like the next one, but the effective factors, we see moderate levels of emotional distress and slightly higher levels of self-regulation. So these women are to some extent feeling distressed about their risk, but at the same time, to some extent, they're feeling that they are able to actually take hold of that and control that distress. Now, in terms of the cognitive factors, across the board, what we're seeing is that moderate to moderate high levels of endorsement. Women are saying that to them they believe lymphedema is a chronic disorder. They're saying that for the most part the symptoms are coming and going. They cycle once you do have that diagnosis. But they're also believing that there are things that both them and their treatments can do to control this risk. They're reporting the same levels of response efficacy and self-efficacy. So they believe that the recommendations do work to minimize risk, and to some extent they believe they can also actually action these recommendations. And illness coherency is also at that same level. So for the most part, women are saying that they do understand lymphedema, and consequences is relatively high. But interestingly, their perceived risk is quite low, and this could be related to the fact that they do perceive that level of control. Now, to actually look at what's related to engagement and what predicts engagement, we used a logistic regression because we asked a yes or no question for seeking medical advice. And on the left, you have all of those cognitive and affective variables that I spoke about before. And on the right, you've got all the demographics that related or correlated with seeking medical advice. These were the things that went into our regression. If we just pull up what was significant now, what we see is that the women that were most likely to be seeking medical advice were also reporting that they had high illness coherency. They understood lymphedema. It made sense to them. It didn't confuse them. They had high levels of response efficacy. They believed that the recommendations actually worked. And they also had high levels of emotional distress, or well, not high, moderate. So they were distressed by their risk. So the message here is that they are distressed. They see it as a bad thing, as a serious condition, but they understand that condition and they believe that there's something that can be done. Interestingly, we also had some demographic and medical variables turn up as significant in the regression. We saw that country of residence differentiated whether or not women were engaging in this, such that our US population were more likely to be engaging in seeking medical advice. And at the same time, we also saw women who had had an axillary clearance were more likely to seek medical advice than those who had sentinel node biopsy. In terms of the other two recommendations that I described earlier, avoiding extreme temperatures, avoiding trauma, they also went into their own logistic regressions. And as before, on the left, you can see all the cognitive and affective variables. On the right, in black, you see the demographics that related. And if I just grey out the non-significance, and it's all wrecked. But basically, the message that we're getting, even though we're seeing different variables come up, we're seeing the exact same message as what we saw with seeking medical advice. It's the women that are adhering to these things are the women that see lymphedema as a serious condition, but they understand that condition and believe that there is something that either they can do or something that can help them to minimise that risk. So in conclusion, there is evidence for the use of psychological factors in understanding why women may or may not engage in these recommendations. Specifically, what we're seeing is that the women who understand lymphedema, who perceive it as a serious condition, but believe there's something that can be done, are the women that are more likely to be adhering and engaging in these recommendations. So, as a discipline, we need to empower women to understand that they can self-manage their risk. We need to reinforce the ease and the effectiveness of the risk management strategies and recommendations, and we have to ensure that women understand the seriousness of the condition. All right? Thank you.